getting close to the thyroid gland. So at the thyroid gland, somewhere around 47-48 gray will get. Similarly, other patient, it was a carcinoma oropharynx T2N2A disease, in which the high risk PTB was coming to the thyroid gland, and with high risk PTB, we don't try to even do any kind of cropping from that. In this patient, if you see the 57.8 gray, that is intermediate risk, it is recipient. So we try to see the coverage of PTB as well as those to the thyroid. And in this case, in first case, we have achieved the D mean of 30 gray and B35 less than 30%. In this again, the second case, we received, we have achieved a D mean of 34 gray and B40 less than 35%, one less than 35%. So what is the summary? Thyroid sparing is feasible, but you have to be careful, maintain low thyroid mean dose when anatomically permissible to maintain the long-term quality of life. Thank you.
And then second is capsular fibrosis and arterial radiation. So that is a plate reaction point of view. So probably this is the thyroid problem is basically the RTOG era, this new IMRT era, because earlier we used to shield the lower neck. The stomach is 2 cm and thyroid width is 2.5 cm. So when we put a center shield, so we are obviously shielding thyroid and not shielding the tumor. And there is main problem arises after we started IMRT AGRT.
Yes, sir, very right.
So can you tell me how you actually titrate the dose so that you don't get the hypothyroidism? And because hypothyroidism is the bigger problem, you get blood oxygen and all things which can take place in life also. So what do you ask for the prevention?
Laterally. Also we do, even then we don't put feeds, we do IMRT, and then not only the axial-lateral, the contralateral thyroid also becomes at start receiving low dosage. So we try in these kind of patients, we give a bit more tighter constraint to the thyroid gland, and like I said, CTD and depending upon the whether it is coming in the zone of lateral disease, we try to achieve a thyroid mean dose around 25 gray. If we are treating, how many patients do you see who recurred, especially in the root region of thyroid gland, just in the region of thyroid gland? If we try to see the recurrences that you get, most of them they do either recur in the primary region or in where the node was there. And like I said, when we do it in low risk zone, then the dosage that have been published, what should be the dosage of the elective nodal irradiation, that is not likely, it should be 50 gray or 54 gray. It can be as low as 45 gray, that we all know. Even 45 gray is considered sufficient doses for elective nodal irradiation. So that is why I said when I try to crop the patient. Obviously I said if you do the cropping, you will definitely have a...
Thank you. A big thank you to Dr. Chaturvedi for this invite and an acknowledgement of all our seniors here, Dr. Fuku and Dr. C.S. Madhu and so many others. It's a pleasure to be here. So the topic here is that how do we, is radiation oncology under threat? I don't know, there will be very promoted issues, discussions on this, they can be, but let's go straight to the point. I have only 10 minutes, so I will aim to keep it. I'll just talk a little bit about the history and how the postgraduate medical education started very quickly. A preliminary summary of our training program, consequences, and why do we need to fix it now? What is happening? What is staring us in the face in terms of ground reality? So, in 1986, the specialty of radiology bifurcates, and all these people, Professor V. Gupta, Professor K. Singh, Dr. Krishnan Nair, Dr. Sanyal, Dr. Saroj Gupte, then Dr. P.K. Haldar in Agra, they had come back from the UK after training. They had done their BPS and then they did their DMRT here. But of course they had periods of house jobs, etc. And then they did their, I think they did their DMRT, some of them did their FRCR. They came back and then they crafted this program then in '86, from where the MD program started, separated from radiology. The point being that, you see, they trained in the UK, and they trained in the UK, but this is today's UK's training program. But what did we do? What are we doing? We do a graduation of 4.5 years, an internship, 3 years of MD, and then we go anywhere from 1 to 3 years more training as well, until quite recently, until the last decade or decade and a half, I would say, when new challenges have cropped up, particularly technological improvements, the systemics that we have been using. There's a lot of medical needs in these patients. By contrast, the surgeons and the medical oncologists here are trained in basic surgery and medicine respectively, and then do their subspecialization, and so they are called specialists and we are not. We know this is simply not true. This is complementing the most important, one of the most important pillars of oncology. But if you look at the UK training, and I'll finish this very quickly here, this is their internship. Everybody needs to undergo medicine, whether or not they do anything. If they have to be MRC, they have to do this medicine training. And then they do about 4 to 5 years, 5 to 6 years of training to become clinical oncologists, which is what we do here as well. Drugs, radiation, palliative care, just taking care of the patients. But they can take care of the patients, and there are challenges that we see here. So what's the summary of it? The medical internship program in ours is 1 year compared to 2 years in the UK, and we do not have a requirement of formal skills in medicine. This was not the case earlier on when we did not have these PG seats, this NEET examination. Everybody would do house jobs. We had 1 to 2 years after MD, we did house jobs, and then we came into a postgraduate training program of 2 years or 3 years, and so on and so forth. So there were skill sets were there. Lots of more things are happening. People are mugging up now. Internships have been diluted in large parts of the country. In some parts of the country, they still remain intact. And so the reflexes when a patient is sick are actually make the current postgraduate a little bit on shaky grounds as we would do that. The same problem is also there with the surgical teams, with the surgical trainees and the medical trainees, but they at least have some basic training. So they're slightly better at managing at least acute cases, acute problems. So what's the story in India today? Training seats and job seen. MD plus DMD seats are 600. This is a rough ballpark figure. It's pretty close to it because we recently had a little brainstorming in SGPG and called people from UP here. The central area register, and please correct me, I think I will be completely wrong because I don't know, maybe having close to 7,000. Professor C.S. Madhu can tell us, or somebody can tell us what is the total number. I don't know, but there will be about 1,800 PGs because 600 times 3 for 3 years. There will be at least, I reckon, these many who are not on the register currently at any point in time. And then most of them will register and come onto the AROI sort of list of membership. Now, after the MD, there's a variable training of 1 to 3 years. It depends. If you want to do a job in an INI, Institute of National Importance, you need 3 years. Medical colleges take 1 year. But those jobs are only 30%, 20% of our sort of opportunities. The major employer is the private sector. Now, the private sector is 70%. The healthcare is also 70% and the private sector. And so we have to go by the rules of the private sector. And the private sector is taking care of the needs. After all, in terms of the total healthcare budget of India, 0.89% is given by Government of India, 1.5% is given by private sector for a total of 2.6%. UK spends 13% of its GDP on healthcare. Just giving small examples. So medical oncologist, he has an upper hand in the private sector. You know, he receives, he investigates, he admits, he treats cancer patients, takes the lead and decides when the patient will go for radiotherapy. Is this not the case? For us seniors here, who are having our own facilities, we do what we have been taught. The current postgraduate is exceedingly disadvantaged. He is now just confined to the mercy of, humoring a colleague who knows not as much. He spent 6 years in oncology or 5 years. The other guy's done 3 years. Doesn't know, hasn't seen radiation very much. This person is skilled. But the other problem that is happening is that when you have the DNBs, in the DNB Institute, the same sort of silos are there, so they are not getting exposed to the systemic therapies because your boss says no to do this, they're not getting hands-on training. So a lot of churning is taking place. Radiation oncologists barely see or get to see and follow. It is highly variable in some places. Different private sector hospitals have their different models, so it's not a general statement, but it is pretty close to what is happening now. And we have to now talk not about the government hospital, the SGPGIs and the AIMS. Let's get real on the ground. And let's face it, wide disparity in salary. The Medon gets 10 lakhs, 12 lakhs, 15 lakhs, and the Radon starts with 4 lakhs, whatever. It's not great, I guess. So, what does an aspiring radiation pass out to do? What will they do? So we have the total number of seats. I've given a range here because these are good estimates because year on year the ranges change. These are pretty close to accurate. You have DNP SS 176 and 159, total anything between 315 to 333 seats. Now, we did some phone calls and talked to people differently in places. While there is no central place where you can find out what proportion of medical oncs were radiation trainees as opposed to medicine or PEDS trainees, but a good figure is over 70%. In some places it is even 80%. It's just maybe in Tata Hospital that is about 60% because they're a little finicky, but most places it is 80%, 70 to 80% of the radons are cracking it. And they are deciding their future. So, how many go? Out of the 600 pass-outs in any year, we are having, and let's face it, I'm not being patronizing, but let's face it, these are the people who are aspiring, who are dynamic, out of the 600, or let us say out of the lot, they're aspiring, dynamic, wish to move up the ladder, and even you find professors in radiotherapy. Recently, I will not take names, sitting way somewhere in some part of the country and doing medical oncology, just because they want the DM mixed there. So what is the reason for all this? We polled a little bit, and that person is here who's probably, I don't want to take names, but one of the senior consultants in our hospital told us, this is the comment that we got from the person when we asked, what is your view on the situation? So this person says, since the last 5 years, there's been an exodus of residents of radiotherapy to medical oncology, nothing new. In departments, in RT departments, most institutional patients are shortage of senior residents. They say, no, there's no future here. Let's go, let's set for the NEET SS and crack it. And they crack it. As teaching faculty, this is very frustrating. You've taught a person, the person is gone from there. What are the reasons? You see, the problem reasons from the resident's point of view is, you see, they say MD or DMD I do, then I get a consultant post, and the pay package is always less than that. It's a big hit to the ego. That's what they say. Sir, acha nahi lagta hai. Hum karenge. We want parity. We also want a big car. There are aspirations. You can't stop it. We can't stop it. Let us see what we can do. Revamping the radiotherapy training, let me just see. Seems justified on first instance. Another person, a senior colleague in a government teaching hospital says, radons are moving towards medons. It is the writing on the wall. Lesser radiation centers in government sector, true. Most of UP, where there are government centers, you can just count on maybe 10 feet on 2 hands the total number of machines. the private sector is really big. Hanuman Prasad Pradhan here has got 3 machines. By way of example, Dr. Chaturvedi's hospital has. I don't know what's happening in medical college, but it's not a reflection. It's not just names, but this is the fact. High technology training for postgraduates are there happening in government centers. If I have to do IMRT, IGRT, SPRT, this, that, and the other, why will I stay there? I will move out from there. I'll go to the private sector and start. At least my bread and butter is assured there. Lack of future in the minds. No parity, no dignity, or less dignity, and in some places they are privileged. They can do systemics and radiotherapy and be the leader, which is what they are meant to be. So, what are the consequences of our training? Because of the way the training program is now structured, a patient who is acutely unwell, whether there is metastasis or organ failure or whatever, you are lost. I want to refer. And if you're giving anti-systemic therapies and they get sick, now what do I do with hyponatremia? What do I do with hyperkalemia, hypokalemia, hypoglycemia, and azotemia and hypomagnesemia? Lost. SVC first send it for CT, then PET CT, then do this, do that. The reflexes are not there because they haven't worked in their internships and etc. Lots of reasons are there. So their training is required. We need to ask ourselves, is an entrant to an MD radiation oncology program equipped with sufficient medicine skills, sufficient to manage common and wide-ranging comorbidities that accompany a patient? Is there an excessive dependence on cross-reference? Is there likely to be a delay in recognition of evolving medical problems? The person is got obtunded, there's a hypomagnesemia, hypocalcemia, hypo this, hypo that, maybe this, maybe it's no way. You have to have faster skills because specialists deteriorate and be seen. Their deaths avoidable. And is there likely a delay also? If you don't recognize the condition, who do you refer to? So, what is the solution? Now this program, the MD program is so packed. You have core subjects, you have oncology, 3-year program. Then NMC tells you, da 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 da. Then district residency program. This is a new kid round the block. It's usually observership, or they send you to radiology, or they send you to medicine. That's it. Then there's a conference presentation, and then you have exams in between. Where is the time to skip in medicine, if you want? Where is the time? So, where do we craft it? During MD? I'm not sure. After MD? I'm too old. I have to move up. Will there be a motivation? Or should it be a second degree after MD medicine or pediatrics? Do you really want to do that? Then what will happen to the vast majority of people who are already trained? What is going to be their fate? And will the AROA agree? Certainly not. If you're all trained, and we don't think that somebody who with medicine who comes and does it will know more than us. And we're not familiar with knowledge. And the broad idea is very simple. 18 months but not 36 months of medicine. Keep it simple. 4.5 years to do what you do in the 4.5 years, 3 years of MD, plus let us say 2 years, 1.5, 2 years of senior residency. I'll make it simple just to tell you that it's thought out. This program is running in AIMS Jodhpur. So you will say now 6 years, so what is going to happen to me? I am an MD, my student will become a DM. But hang on a minute. What do these DM entrants talk about? These people. It is running in the 6th year in AIMS Jodhpur. I may tell you. So here's the feeling, and this has come straight from the horse's mouth. Running in its 6th year, what do students have to say? Holistic pros of the program. Holistic feeling. Tools of radiation, chemo, immuno, all available as arsenals. The medicine training removes fear of taking care of comorbidities and emergency reflexes. They know it like this. They don't have to bang on the medicine guy. They say, okay, I'll be able to do this, I'll be able to do the ABG, I'll be able to put in the vent, I'll be able to put in the PIC line, finish. Cons. In the commercially driven market, which is the true test, which is the Kurukshetra, which is the battleground, how will the corporate sector react? Now this is a financial question. There's a billing for chemo, there's a billing for the radio. Maybe somebody thinks that a one man doing both is good value for money, but then the billing is an issue, whatever is happening. So these are their questions. It is not a program without questions. In the academic universities in India, what sort of job will they get? MD radiotherapy will surrender its seats. A new program will start. What will happen? There are still questions. Okay. So what are the solutions? I have no solutions to offer. Just a thought. At this point in time, the solution is that for those who have finished their PG in Radon, a lateral entry into a DM radiotherapy oncology for a 3-year program, where you put a bit of medicine and then you put the rest of it as clinical oncology, but you write the same papers again and pass it. But this time, you would have had a formal training of medicine and you have already got a good grounding of the subject. You can expand on it and do better for those who are already trained. This will not be open to anybody else. We have to put this proposal forward, and this is just a seed in your mind whether this is possible. The second is, apply to the NMC for an integrated DM program. This is open now, I may tell you. So, it is open, integrated 6-year programs are open. If you would like to know how to apply, you can get in touch with some of us. The pass-outs will be independent and self-sustaining. Even if there is no job, the gentleman will sit, he can do palliative care, he can do systemics, and he can go on a consultancy basis to the different hospitals and treat his patient also. So it is a far more workable solution, and there will be no redundancy, and they will always be useful to society and therefore always in demand. But more importantly, a sense of dignity and an identity as a specialist. Thank you very much.
So now the solution you have given is that maybe after MD radiotherapy we do 3 years DM, which kind of re-energizes us for medicine and along with clinical oncology. Although it is a good solution, but will we be treated on parity? There is a very big dilemma among radiation budget that they are poorer in clinical medicine. We see each and every day. Although we need a solution. It's not that we don't need, we need. But I think whether this is the solution, 6 years or I don't know, but medical oncologists are getting more money if we are talking of money because of their specialty, because the drugs they use, that they bring in more revenues for hospital and
See, think of the pulmonary medicine and respiratory medicine. What are they doing? There is MD in respiratory medicine and DM in pulmonary medicine. They are doing the same work. There is no controversy. Very often in some of the departments, both the courses are being conducted. But on paper, they may show it as 2 departments. So like that, a DM radiotherapy is not going to jeopardize the existing radiation oncologists who are just MD. So there will be a transition, and it will be smoothly done, and we should do this. And with regard to the guys who are going for medical oncology DM, what I have seen is now in Kerala, so for example, there are a lot of people with the DM after the MD radiation. Now there also job problems are creeping in, and they are getting low salary. All these things are happening. So I think it is, even some of the medical oncologists are telling that there should be a unified course. And also you can hear from some of the top medical oncologists in Kerala, because otherwise there will be too many people. So what we want is an integrated course, no doubt about it. And there should not be any restriction on the part of the radiation oncologist to say prescribe temozolomide when he is treating a case treat germs and tumors, etc. Because during our time, there were no medical oncologists. But now the scenario has changed. There is no threat from any of the existing so-called radiation oncologists. But for the future of our youngsters, I think we have to gradually start DM radiotherapy and oncology as it is started in Jodhpur, and more centers should apply for it. The NMC has agreed to accept proposals from broad specialty departments to conduct super specialty courses. So there are no problems in starting a DM radiotherapy and oncology course in an existing radiotherapy department. So what we want is unity in our thinking. I think we should go ahead with this.
Of our career, and we are seeing the new generation and seeing them running out from radiation oncology. Thing is, while they are moving to medical oncology, may not very minimal aspect, and since you see, as you showed that we have no time to think and really make original thinking and contributing to the field. We are so much overwhelmed when we go to our department. We are busy with round and then all OPDs and IPDs on contouring and follow-up, that till evening you don't get time to think seriously about what new things you can do. That's the thing. And we also don't train our student for basic managing the basic patients. We rather get them involved totally in very mundane things, I believe. We think that yes, if we are done contouring, we are a very great oncologist. But that is not the thing. These are important part, but we must think above those things. So just putting a DM degree will not improve your prospect, what I feel. You see, what people, why do they pay more to a particular doctor? Because they are generating more. So are we going to generate more after a DM degree? I think this question there. Thing is, even for our MD degree, we have to strengthen our training program and our students, so that they become more efficient and powerful. When they become powerful, they will decide the total management and they will get the prominence and strength. So strengthening this MD radiotherapy program, I think we should all sit together and making so that when this is very right time that we think over it and strengthen our training and other programs so that we produce a really good clinician who is an oncologist, who is a clinical oncologist, who take care of all the aspects of the thing. Because we have the facility. We are radiation oncologists, you can
रिजेक्ट हो चुका है, बार-बार इसको क्यों प्रेजेंट किया जाता है, हम लोगों को क्यों ये किया जा रहा है कि हम इसको एक्सेप्ट करें, दिस इज वेरी डिफिकल्ट टू डाइजेस्ट। दूसरी बात है कि हम ख्याली पुकाव बनाना बंद करें, 5-6 साल से ये डिस्कशन चल रहा है और हम कर कुछ भी नहीं रहे। और तीसरी बात, दूसरे को कुछ कहने से अच्छा है कि हम अपना घर पहले ठीक करें। जैसे डॉक्टर साहिब ने सही कहा कि पहले हम अपने रेजिडेंट्स को ठीक तरीके से पढ़ाएं सिखाएं, तो ऑप्थेल्मोलॉजिस्ट को कौन सी मेडिसिन आती है, ENT वाले को कौन सी मेडिसिन आती है, बट वो अपनी स्पेशलिटी की प्रैक्टिस कर रहा है कि नहीं कर रहा है। मैं SCPGI का स्टूडेंट हूँ, आपसे क्षमा चाहता हूँ, हमें कभी ये नहीं सिखाया गया कि IV लाइन कैसे लगाते हैं, हमें कभी ये नहीं सिखाया गया कि कोई मेडिकल इमरजेंसी आती है तो कैसे मैनेज करते हैं। तो जब हम उसे सिखाएंगे ही नहीं तो वो सीखेगा कैसे। और रही बात, आप खुद अपने दिल पे हाथ रख के करिए, 18 महीने जो आपने करिकुलम दिया, 18 महीने मेडिसिन सीखने के बाद कोई रेडियोथेरेपी सीखना चाहेगा? 18 महीने की मेडिसिन सीखने के बाद वो आराम से प्रैक्टिस करेगा मेडिसिन की, रेडियोथेरेपी नहीं करेगा।
और रही बात ये कंपेयर करने की मेडिकल ऑन्कोलॉजी ज़्यादा पैसे लेते हैं, ज़्यादा पैसे का तो अच्छे पैसे मिल रहे हैं, तो हम ये क्यों सोचते हैं? कभी आप आइए तो हम आपको कॉर्पोरेट हॉस्पिटल में उनका रेवेन्यू दिखाते हैं और हम अपना रेवेन्यू दिखाते हैं। न्यूरो सर्जन और आप एक जनरल सर्जन को कैसे कंपेयर कर सकते हैं? न्यूरो सर्जन 4 सर्जरी करता है, ज़्यादा पैसे कमाता है, जनरल सर्जन कम कमाता है। अब थर्मोलॉजिस्ट कैटरेक्ट की सर्जरी करता रह जाता है, जिंदगी में उतने पैसे नहीं कमा पाता। तो इस चीज़ को इस चीज़ से कंपेयर नहीं करना चाहिए कि वो 10 करोड़ का पैकेज ले रहा है, 15 करोड़ का पैकेज ले रहा है, तो वो हॉस्पिटल को उतना जनरेट करके भी तो दे रहा है ना। वो हॉस्पिटल उसको उसका शेयर देता है। वो 15 करोड़ जनरेट करता है, हॉस्पिटल उसको 10% दे देता है। आप ही रेडिएशन में 15 करोड़ जनरेट करके दे दीजिए, आपको भी उतना ही मिलेगा। बहुत से दिल्ली में रेडिएशन ऑन्कोलॉजिस्ट हैं जो कई मेडिकल ऑन्कोलॉजिस्ट से ज़्यादा पैसे कमा रहे हैं।
Okay.
तो इसलिए
I think we had enough.
Sir, last.
We all know Dr. Pant, and every year at UPAROICON, we remember Professor Mohan Chandra Pant whenever this oration is delivered. His life and work embodied the true spirit of medicine, compassion, integrity, and an unwavering dedication to healing. His life touched patients, students, and colleagues alike. Professor Pant was born on October 11, 1956 in village of Kunkoli, Ranikhet. His preliminary education was in the village school and higher education was at Mission College at Ranikhet. After obtaining MBBS in 1979 and MD in 1985 from KG Medical College, he joined in alma mater as a lecturer. He had specialized training in Japan and established a CT scan center at KGMC. He was known for establishing a lot of medical institutions, including Lucknow Cancer Institute, Swami Ram Memorial Cancer Hospital Research Center in Dehradun, Dr. Sushila Tiwari Memorial Cancer Hospital in Haldwani, and Rural Cancer Center in Manipuri. He later became head of the department of King George's Medical College Radiotherapy Department. Following that, he became director of Dr. Ram Manohar Lohia Institute of Medical Sciences and was instrumental in setting up a super specialty medical institute in Lucknow. Recognizing his extraordinary capability, he was selected as Vice Chancellor of Himati Nanda Bahuguna Uttarakhand Medical University, Dehradun, by the Uttarakhand government. He was passionate about cancer prevention work and established a cancer detection center for early cancer detection and prevention as social responsibility. His notable contribution in this regard is noteworthy in the district of Uttarakhand almost for 2 decades. He relentlessly conducted cancer education and cancer detection program in 23 districts in Uttar Pradesh, and it had benefited more than 7 lakhs people, and Government of India recognized this by offering him Padma Shri in 2008. He published 89 research papers in various international and national medical journals and also authored 5 books on cancer and 10 books on cancer control and prevention in Hindi. Professor Pant was honored and given awards by about 15 national and international bodies, which included B.C. Roy National Award and DSC by Kumaon University in 2008. Professor Pant was closely associated with AROI for more than 3 decades. By a selfless contribution to the development of the association, he gradually climbed from the ordinary member to the coveted post of President of AROI in 2014. August 13, 2015 was a gloomy day for the radiation oncologists of this country. It was difficult for them to fathom Professor M.C. Pant, our beloved president of the association, was no more. The whole oncology community was wonderstruck by the sudden demise of this stalwart. Those of us who interacted with him closely knew how gentle and affectionate person he was, and there are a lot of people in this audience who knew him very well. Personally, I lost a very good friend. Professor Pant was a symbol of benevolence. There is a saying among his colleagues that no one returned empty-handed from his chamber. He helped everyone to the best of his capacity, be it a patient, a junior, a staff member, or a colleague. That is the personality we lost, the vacuum of which is impossible to fill. Dr. Pant was survived by his wife, Srimati Nirmala Pant, and 2 children, Siddharth, who trained as radiation oncologist, and finally is training as a medical oncologist. the subject which Shalin just said, and Shraddha, who is a BTech. In October 1987, when I joined SGPGI, a few days later, Pant, as I called him, came to SGPGI to meet me, and since then we became very good friends till the time he left us. He appointed me as director of the board of Lucknow Cancer Institute, which he established, and we discussed how to make that place best in Lucknow. We became, we started knowing each other much more when we traveled to UICC meeting in Oslo, to Sweden, and later to a meeting in Japan. He was in discussion with me to set up a larger cancer center on the outskirts of Lucknow, but he could not do so because of his illness. Before I go further, one small anecdote I want to share which will tell you the personality of Pant. When I was completing my presidentship of AROI in 2012, a few months before that we were discussing, and we thought that Pant would be a very good candidate for the next AROI president. So once the nominations were called, Pant filed his nomination for the next president of AROI in 2012. A few weeks later, another nomination came, and that nomination was from Dr. Ramesh Pilimata. Pant called me immediately the next day, and he said, I have come to know that Ramesh has applied for the post of president of AROI. I am withdrawing. I said, Pant, we have discussed so many, for such a long time, and you filed your nomination, and now suddenly you say, I am withdrawing my nomination? What happened? Pant said that Ramesh Pilimata is a person who donated his kidney to his dear friend, Dr. Gurunath Kilara, who was also a very known radiation oncologist and my batchmate, when all his relatives were either found unfit or they did not, donate his kidney. So since Ramesh donated his kidney for the dear friend and colleague, I have a great regard for him, and if he is fighting for the post of AROI president, I will not. And he will do his nomination. Next year, in 2014, he of course filed the nomination, but as we all know, he could not complete his tenure because of his demise. So that is, the person Pant was. And he was very close to his colleagues and patients, and therefore when this question came, I was trying to think what to speak. And so I selected this topic, which I thought is very appropriate in the memory of such a person who cared a lot about his patients. This is a different, side of oncology. We all in the meetings and in day-to-day discourses discuss a lot about technology. And we always feel pride in having, a technology, a newer technology at our center, how well we are doing with that technology. But is the other side also important? We will see in the next few minutes. And I will try to tell you what should be done through a few real-life stories, and I think you will understand what I mean. Amid unprecedented scientific progress in oncology, a growing body of evidence reveals a parallel and profound crisis in the human experience of cancer care. Despite overall survival outcomes improving, the systems designed to deliver care increasingly fall short in addressing the emotional, relational, and existential dimensions of cancer. Although examples of compassionate cancer care exist in every hospital, in every city, but patients and families across global contexts continue to report being unheard, unsupported, both emotionally and financially, and at times actively harmed by care structures that prioritize technical precision over human care. The human crisis of cancer is not defined by pathology, mortality, or cause, but by the erosion of meaning, connection, and compassion in the experience of cancer. The crisis is shaped by what is present and what is absent. The presence of fragmented, costly, and impersonal systems and the absence of human connection
psychological safety and relational care is a big question. It is a crisis that spans delivery, mental health, palliative care, research and education, one that is not peripheral to oncology but central to oncology. It is a system-level failure that ripples across every context, from the most resource-rich country to the resource-depleted country. There is a growing imbalance between technological innovation and human dimensions of cancer care. As the field has increasingly prioritized biopharmaceutical development, genomic precision, and market-driven efficiencies, it has often neglected core practices that uphold dignity, alleviate the suffering, and build trust with your patients. Today, I am trying to remind each one of you sitting in this hall that only looking after the technology is not enough, only taking care of the beam is not enough, but you should look and try to look beyond the beam. In healthcare in general and oncology in particular, the importance of personal connection cannot be overstated. While technology plays an essential role in modern medicine, the healing power of human touch and emotional presence of a physician remains irreplaceable. In a recent survey, 95% of the physicians believe that patients respond better to healthcare professionals who demonstrate empathy and compassion, according to a poll published recently, but 71% of the doctors express concern that they often fail to show vulnerability and genuine emotion in their day-to-day jobs, which could negatively impact patient outcomes. We all know this, but today I am reminding you to try to incorporate this dimension in your day-to-day practice. A very famous physician, Canadian physician William Osler, often described as the father of modern medicine, once said that medicine is the science of uncertainty and the art of probability. Medicine is based on research and evidence, but no matter how advanced science becomes, there is always uncertainty, and all of us who treat cancer know and agree with this statement much more than any other specialist. Every patient is unique, but no two cases are ever exactly the same. We have to make decisions not with absolute certainty, but with best possible judgment based on probability and experience. That is where the art of medicine begins and the art of observation, intuition and empathy comes in. It's about combining scientific knowledge with human understanding to make the best choices for each individual. And healing extends beyond technology, as I said. It lives in connection. Technology expands our capability, but empathy preserves our humanity. We all talk about AI, adaptive radiotherapy and imaging to enhance our practice, but it cannot replace human care. Now, three things are very important. Empathy, I think all of you know, is very different from sympathy. Our patients don't need our sympathy. Now, sympathy is when I tell my patient that I am very sorry for you. Patient doesn't need that. Patient needs empathy, and empathy means that I am not sorry for you, but I feel for you. When a patient says that I am scared about my diagnosis, I don't know what is going to happen, your reply should be that I can understand what you feel, and it is normal to be anxious, let's talk about it. The other important thing is compassion, awareness of other person's suffering with genuine desire to help, to relieve the suffering. Empathy is that I feel your pain, and compassion is that I want to help and ease your pain. And third is communication. Ability to help you share information, verbal, non-verbal, body language, facial expression, gestures, eye contact, the tone of voice and touch. In the present day scenario, when you sit in the OPD, where most of the hospitals have a computer to type, you don't even look at the patient. You are, talking to the patient, looking to the computer, typing your things, and when you do not make an eye contact with the patient feels really sad. To the extent that in one lecture I was listening, the Hyderabad Institute said that because the doctor has no time to have eye contact, they have developed an AI program where the doctor will look at the patient, talk to the patient, and that talk will be recorded and the AI will type the prescription. So that is very important to have a touch, to have a look, to talk softly with the patient. We all know this. This is not a new thing which I am telling you. But you should ask yourself how many of us are doing that. A tap on the shoulder, shaking hands, communicating that I am with you. It helps chemically or biologically also. When you put your hand on the patient, of course you should have, personal boundaries should be respected. It lowers cholesterol, stress, heart rate, anxiety, and a lot of good things are done. These days, I remember one instance of one of my residents a few years ago. He, a patient of MRM, he was doing simulation, and he came to me after a CT scan that, sir, there is a lot of air in the chest wall. I said, air in the chest wall? What happened? Did you examine the patient? He said, no sir, I did not put my hand, I did not examine the patient. I said, go and examine the patient. Now that patient had an open wound, and the surgeon said that, it is healing by secondary intention, and that wound caused the air into the chest wall. This guy completed all the simulation, took a lot of history, talked everything, but did not did not examine the patient. So that is also some of the important things. The patient feels that if the doctor is doing everything and is not examining me, what sort of impression the patient will get. So art of listening is also very important. All of you remember when we were doing our MBBS, we were taught how to take the history, and history taking is actually the art of listening. We spent substantial time teaching our students what to say and what not, and not enough time teaching them how to listen. Hippocrates believed that careful listening to patient stories held the key to revealing diagnostic and therapeutic tools. The first clinical skill that medical oncologists, medical students practice is how to elicit a patient's history, listen actively, and reflect on patient's unique story to develop a problem-based assessment and plan. We drift away from this virtue when we start practicing medicine. Most of us, will hear a few words from the patient and then start talking. You don't give patient time, and that there are many reasons for that. Public hospitals, there are hundreds of patients to be seen every day. The OPD slots in private sector are given 15 to 20 minutes. In those 15 to 20 minutes, you have to do the whole thing. So, we read this, we know this, but we don't practice this. Now, let me share 3 real-world stories with you. And these real-world stories will actually tell you the actual, situation in our clinics. The first story comes from a colleague of mine who works with me in my hospital. And during a conversation, he talked about his illness. And I will tell you what he talked. He narrated his story not as a senior oncologist, but as a cancer patient himself. His conversation offered a rare and powerful glimpse into what happens when healers become patients, and how such journeys reshape the meaning of care. For a senior oncologist, being diagnosed with cancer creates a unique paradox, knowing too much about the disease and prognosis, but having very little control. He said, knowing the side effects and prognosis never scared me. It helped me cope. I knew the odds, but I also knew the possibilities. That perspective made me resilient. But beyond clinical knowledge, the experience fundamentally shifted his outlook towards patients. What he experienced during his illness changed his outlook towards his patients in future. He said, I always believed I was empathetic, but becoming a patient has made me listen more deeply to my patients thereafter. Every patient is someone's family member, I realized. Every loss takes a piece of your heart, he reflected. This new lens, he said, has made me both more patient and more present in every consultation with my patient after I recovered and started my practice again. He said cancer journeys are never solitary. And for him, his family became his greatest source of strength. His son, who was staying outside, flew in. He was an oncologist. His wife and daughter stood by him through every treatment cycle, hospital admission and moment of uncertainty. He shared the reasons of resilience. Resilience means ability to bounce back from difficult situations by adapting to stress and adversity. Resilience is about having capacity to cope, recover, and move forward after facing challenges. He said, "My family was my anchor and my rock. That support gave me the strength to face uncertainty without fear. Their presence reinforced his belief that oncology care must extend beyond the patient to include the patient's family." So that is a very important and pertinent point, he said. And the families also carry emotional and psychological burden of the disease along with the patient. This conversation also shed light on systemic shortcomings in India's cancer care ecosystem. We thought that our hospital is one of the best in oncology, but while in the same hospital we experienced a lot of shortcomings in the ancillary staff, in trained dietitians, in counselors, in rehabilitation experts, and psychosocial support teams. In India, he said, we lack such institutional mechanisms. Doctors and nurses need as much emotional support as patients do, he said, underlining the importance of mental health for caregivers. Despite the medical complexities, his message was clear. Resilience begins with hope. Positivity does not mean denial. It means giving patients hope to live one more day, one more week, one more year, and thereafter. Whether through spiritual practices, reading, or simply staying connected, the hope is of lifetime. He also stressed that patient care should focus not only on survival, but on quality of life, and we should address fatigue, nutrition, mental well-being, and dignity in treatment. For him, spirituality and mindful acceptance played a vital role as clinical interventions did. His journey underscored the universal truth. Cancer care is not just about medical protocols, it is about human connections, empathy, and resilience. And his story brought to life what data often misses. That behind every diagnosis is a patient, a family, and behind every doctor's coat is a patient's gown. So you should understand that. This story serves as a reminder that medicine is both science and art, and sometimes the most profound lessons come when doctors themselves experience the vulnerability of the illness. The second story comes from America, and this is also an oncologist, Dr. Emily Chan, whose mother was diagnosed with stage 4 lung cancer. She always prided herself on her clinical skills and knowledge. However, her perspective shifted dramatically when her mother was diagnosed with stage 4 lung cancer, and this personal crisis allowed Dr. Chan to experience the healthcare system from the patient's side for the first time. She witnessed firsthand the confusion and fear that patients often feel. She observed how her mother struggled with the complex medical language and overwhelming treatment options presented to her by the doctor. Recognizing this gap in communication, Dr. Chen began taking extra time to explain medical terms in simple language and answer questions thoroughly, not just for her mother, but all of her patients in the clinic. Inspired by her mother's experience, Dr. Chen established a patient advocacy program within her department, and this initiative trained staff to prioritize empathetic communication, ensuring that patients felt heard and understood their treatment journey. Our program has since empowered countless patients to take an active role in their care, demonstrating how empathy can transform clinical instructions into collaborative partnership. And the third story comes from Mexico. The nurse, Maria Gonzalez, who worked as a busy oncology ward in a hospital in Mexico, where she regularly cared for terminally ill patients. One particular patient, Mr. Thompson, had been battling cancer for several years. As his condition worsened, he became increasingly withdrawn and despondent. Recognizing that Mr. Thompson needed more than just medical treatment, Nurse Gonzalez dedicated time each day to sit with him during his shifts. During her shifts, she learned about his passions, including painting and classical music. Understanding how important these elements were to him, she brought art supplies, played his favorite music during her visits, and her efforts gradually transformed Mr. Thompson's mood. He began to express himself through painting and even created beautiful pieces that brought joy to other patients and staff members alike. Maria's empathy allowed Mr. Thompson to regain a sense of purpose in his final days, reminding everyone on the ward of healing power of human connections. So these three stories from a real-world healthcare scenario have profound impact that empathy can have on patient care and health outcomes. by prioritizing compassion, whether through advocacy programs or personal connections, attentive listening or community engagement, healthcare professionals can make a significant change in their patients' lives. Now, we oncologists have the human side. Oncology is one of the medical specialties where human side is most tested and most necessary. All diseases, all patients of all diseases need help and compassion, but cancer patients need that much more. Without empathy, patients' emotional awareness, cancer care will be far less effective and far more traumatic for patients. It is shaped by experience, personality, training, and emotional intelligence. As I said, our patients are different because disease does not affect the body, it affects the mind and emotions and social life. Diagnosis instills fear, anxiety, and depression, resulting into stress, affecting treatment outcomes. Difficult for patients to make informed, confident decisions about complex treatments. Discussion about side effects and survival chances are emotionally charged, and adherence to treatment plans and follow-up is very essential. Patient journey is a long journey to survivorship. Fear, trust, and courage and hope have to be, fear has to be removed, trust has to be generated, courage has to be decided, and hope has to be given. Our role is to guide patients beyond the fear of the unknown. In radiation oncology, we have to blend precision and compassion. Our tools are technical, but our mission, it should be profoundly human. Medical knowledge treats the disease, but the human side heals the person. We all know this. And a doctor without a human dimension risks becoming technically skilled, but emotionally distant, which can compromise patient care. The team, as we know, is very important. Howsoever good the doctors are, the technicians have to be good, the nurses have to be good. Everyone has a part to play. And we all know the chain is strong as its weakest link. Even if all parts are strong, a single weak point can cause the entire thing to fail. So every team member has a responsibility. A small story again, a 80-year-old retired professor treated for prostate cancer, bladder protocol, had to hold the urine. During simulation, it was seen that he can hold the urine for about 45 to 60 minutes. The bladder becomes full in 30 minutes. So he went inside the room, told the technologist that I cannot hold the urine. Can you take me a little early for treatment? The technologist obliged. So when he went on the table, he had dribbled a few drops of urine on the table. After 2 days again that happened, he went again inside the room asking the technologist to take him early. The technologist became angry. He said, every day you come and you try to get treated before the appointment time, I will not take it. But he requested again and again, so he was taken in. That day he urinated on the table. The whole thing became a mess. When he came out, the technologist reprimanded him. He said, I told you, what have you done? And I have to call the cleaners and this and that, and you have spoiled the whole thing. Other patients are waiting. Now this professor did not tell this to the doctor because he realized that if he complained, the doctor will scold the technologist, and the technologist may do something wrong while treatment. So he suffered and suffered and suffered. So this story tells us that if one member of the team is not compassionate or doesn't think about the problems this patient is having, the whole team gets a bad name. So this is very important to see that everybody behaves in the same way. Now, the thing was talked about curriculum, it was never given importance, but lately in other countries it has started much earlier, but in India in 2019, the National Medical Commission introduced the Attitude, Ethics and Communication module as part of the undergraduate medical curriculum to make students understand the importance of these things in patient care. The caregivers, as I said, also have to be regarded. Beyond the science, the statistics, the state-of-the-art treatments, oncology at its core is deeply human field. What I am telling you is nothing new. All of you know. It is only that you have to inculcate into your day-to-day practice so that the treatment which you give is much more successful. It is never written or taught in the books, but it is the experience of each one of us in our clinic that the patient who is happy during the treatment, who is not scared of the treatment, the results are always good. And if you see a patient who is very fearful, throughout the treatment he says that I will not survive, the results are really bad. This has been seen by each one of us in the clinic. It is not written in any book. So if we make the patient happy, probably we will get more recognition for a better treatment and better results. Training empathy and reflective practice is as vital as mastering technology. Beyond the beam lies the heart of care. Let's continue to humanize every interaction, every patient and every being. About listening, understanding and standing beside the patient and families through one of their most vulnerable moments should be our job. In addition to giving them the best possible treatment, let us bring humanity in every encounter to see that just the illness, but the person who carries it is also looked after, and maybe as radiation oncologists continue to bridge science with soul in the care we give and the lives we touch. Thank you very much for your attention and thanks to your for being here.
Thank you, sir, for very enriching talk. Please be on the stage for the further felicitation process.
C.S. Madhu, please come on the stage. And Dr. Vipal, Padbhushan,
Sir, in recognition of his valuable contribution in the field of radiation oncology. So we all should clap for him and.
Sir, wait, sir, look your camera. Okay, sir. Look here, camera इधर.
very nice.
Okay, thank you.
Sir, look here.
May I now, with due respect, invite our chairperson as a token of gratitude from the organizing committee. Please, sir.
जाना पड़ेगा का?
Okay, sir. Sir, camera look. Okay, sir. Sir, look at your camera. Look here.
Thank you both for gracing this session and sharing your vision of your valuable time and guidance. Thank you all for gracing this session.
Dr. Devansh, that time you were Government Department, SDPDI. He is not the that time secretary, Devansh Chaturvedi.
get in Dr. Shreyan. He was head of department, SM Medical College, Ahmedabad. And then he joined Karnataka Koda, and this was the picture of their life. During lunch hours, Dr. Mani, Dr. Sapna Nagia. Sapna Nagia, you can see how slim she was. Ajay, I think you are. Dr. I.C. Khare, Sapna Nagia. You might be meeting these people often. This was in 2011. Now you can recognize your faces. Those who are head of department. Dr. Survi Gupta. This is the whole team in 2011 when it was held in Clark Hotel. Dr. Udu was also there. I think he was not there. Dr. Paul, Dr. Pan, me, yes, Dr. Udu was there. Punita Lal, Sapna Nagia, and so this was the whole story. I started my career in 1984 in Gorakhpur and thereafter joined Kotar Hospital. One conference I did there, another when I started my own hospital in 2000. So this was Dr. U.P. Sai. So this was 2011. We put my cohort in 2006 and now we have started. It's under installation. Hopefully within a month we will get approval for treatment. So thank you very much.
We can have a 5 to 10 minute of tea break and we can continue with the next session as well. But let's come back up.
Ma'am, look your camera. Hello, ma'am.
It lies in the selection of right patient for right target. There are a spectrum of conditions where the radiation therapy in breast cancer is indicated that can be broadly grouped into two: the post-mastectomy or whole breast or with or partial breast irradiation. That is the post-mastectomy or post-lumpectomy situations with lymph node irradiation or without lymph node irradiation. The first scenario, the post-mastectomy scenario, the target is the chest wall and SCF, unexplored SCF with or without IMC. What are the right patients for this? All patients who are node positive, who are T3, T4. The cases, the T1, T2 node negative, that are conditional, they are either not available or there are conditions. there may be reduction of CTV in those conditions or advancement of CTV in high risk cases. Like if the patient is upfront post-MRM with clinical and pathological stage T1, T2 and 0, then these patients may not eligible for post-mastectomy radiation therapy. But the cases who are clinically T1, T2 and 0 but pathologically somewhere detected node positive status either in microscopic or low burden, then if that patient also having the high unfavorable clinical pathological features like TNBC, grade 3, LVI, young age, or centrally medially located tumor, then these patients may be offered for post-mastectomy radiation therapy. The cases who are T3 pathologically with favorable clinico-pathologic feature may be de-escalated to chest wall only or maybe with no TFRT to be discussed. The second scenario will be the post-NACT where T1, T2 who have achieved pathological CR may omit radiation therapy in these cases, but those who not able to achieve complete CR or stable disease may be, if having multiple risk factors, may be offered radiation therapy. And the node positive T3 or T3 and 0 post NACT, no CR with high risk feature to be considered for post-mastectomy radiation therapy. The water condition where the whole-based radiation therapy to be offered, that is, it is integral part of the big breast conjunctival surgery and to be offered in all cases where BCS is done. Where we can omit, it is the older age patient elderly above 70, T1 and 0 ER positive on endocrine therapy. Here there is no OS advantage, but there is a 10% chance of local regional relapse. So that to be discussed and maybe this patient to be offered for ABPI. For the patient who is offered for regional lymph node radiation, that more than 4 node positive or 1 to 3 node positive with high risk feature. No nodal irradiation, node negative, localized tumor, T1, T2. Response of neoadjuvant radiation therapy does not change indication. What we gain in post lumpectomy cases, we gain around 16% reduction in local regional recurrences and 4% reduction in mortality. And post mastectomy cases, 60 to 70% reduction in local regional recurrences and 20-year mortality by 5 to 8%. The systemic therapy in this era, advanced systemic chemotherapy does not change the scenario. The node negative low risk cases may have lower benefit, lower magnitude of benefit may be avoided from radiation therapy. What is the target? The point to remember during planning for target delineation is to place the wire around the clinical field. Whatever the target for whole breast or post mastectomy, what are the clinical field to be wired. If the center is having practicing 2D, tangential field, so no CTV to be controlled. If not practicing CT-based planning, and the tangent for chest wall radiation therapy is the 2 tangent. If only chest wall radiation therapy and direct anterior for SCF is that required. and the target is the chest wall from first rib to inframammary crease around 2 centimeter margin, and medially from mid axilla to medially from mid external line to mid axilla. And for breast, it is the whole breast. How to delineate right target in adjuvant setting? In clinically, if from the first rib to intramammary with 2 centimeter margin, mid external to mid axillary, and if whole breast, then whole breast. We already discussed, not to forget wire, and all the drain side and scar to be wired. What are the standard tangent border? It is for standard tangent are the first superior border is the second intercostal space or first intercostal space depending upon the upper edge of breast, and lower is around 1 to 2 centimeter from inframammary fold if the breast, so if whole breast, if post-mastectomy, then take the reference of opposite breast. Medially, it is the mid external line, laterally is the mid axillary line. There is a term discussed high tangent in the G11 and NSPP trial, where the the axillary lymph node dissection versus axillary lymph node radiation was discussed in sentinel node positive micrometastatic cases. Is right. What is that? It is the standard tangent, but a superior border is little bit raised up to the humeral head. What it gives? It gives a partial coverage of level 2 and full coverage of level 1. In case of early breast cancer with sentinel lymph node positive micrometastatic, these are the cases who can be practiced with the high tangent. What are the wide or deep tangent clinical field? Sometimes we face there is an extended scar crossing the midline, then they are called extended medial, extended tangent, they require extended tangent, or when we require to treat IMC node. Or sometimes there is a lateral extension, deep lateral extension, then we have to little bit deep, we have to move lateral border, little bit down to cover lateral scar, then it is called extended lateral tangent or deep tangent. What are the clinical supraclavicular field? It is the upper edge, the lower edge of this is the upper edge of the tangent, and upper superior is the low caudal edge of cricoid cut, and medially it is the trachea, medial border of the trachea. Laterally is the tip of acromion, that includes level 3. CT based contouring, if we discuss it, the first attempt was tried in 2009 by Chaturvedi group to standardize the radiation therapy contouring, and it is the base of all contouring guidelines which are subsequently published based on the pattern of recurrences or based on the consensus like DBCG Danish group, which are having the largest follow-up of 30 years, and they have published the pattern of recurrence-based contouring guideline or ProCat guideline. They have incorporated vessel-based contouring guideline because most of lymph nodes are around the vessels, and that is adopted by ISRO. If we talk about the RTOD, there are 3 targets for primary. It may be whole breast or chest only, or breast with the chest wall in advanced cases. There is here the table is anterior, so the point to be remembered is the anterior border and posterior border which subsequently change. Here the anterior border is skin, posterior border is the
costal pleural surface in chest wall cases. And in whole breast cases, they have, if locally advanced, then chest pleural surface. If early stage, then they have excluded. And there is also change in the medial and lateral border, which we will see in subsequent slide. The regional lymph node, they have proposed 5 regional lymph nodes: supraclavicular, axilla, in 3 levels, 1, 2, 3, and internal memory. Not going in one detail, everyone knows. Key differences. What are the key differences which come in CTP breast? In estro, there is the anterior border, which in this they have kept about 5 mm beneath the skin. In both, whether it is chest wall or whole breast. And medial border is the medial memory branch of internal thoracic artery, which is external or correspond to external area on chest wall. External area, costal, external junction. And lateral border or lateral is the anterior to the lateral thoracic artery. And here the posterior is the they have not included the pectoralis major or intercostal muscles. Then Susi Periolita and one Chinese study has studied the pattern of recurrences based on the RTOT and ISTO guidelines, and they have found the most of pattern of prominent pattern of recurrence is the superficial skin or subcutaneous or up to above the pect minor. Hardly or rarely patient is recurring in the ribs or intercostal muscles, and they try to figure out what are the cases who have recurred in the rib and chest wall. That cases to be only considered for the chest pleural interface for posterior border. Rest of cases to be excluded, and the posterior border comes superficially in the all cases. So what are those cases? These are the high T stage, T3, T4, node positive, heavy node positivity, pectoralis, ACI involvement or chest wall invasion, vast profile, molecular profile, HER2 positive or TNBC. And they also try to figure out who are having higher recurrence for the scar. These are the skin infiltration, dermal lymphatics, and inflammatory breast. What then this they have suggested, and that incorporated by updated version of the ISTO et al. Guideline, they have removed the posterior. They have bring posterior edge superficial in the low risk cases, and chest pleural surface is kept reserved for the high risk cases. And they have also proposed addition of the bolus. We practice 50% bolus in post-mastectomy cases and 50% no bolus plan. There are variations, there is no standardization in bolus, but some is practicing only on the scar, some practicing whole chest, that is variation. This is the work classification, which everyone knows. What is the difference between the ISTO and RTOG contouring levels? RTOG, they are level 1, 2, 3. Apart from that, supraclavicular internal memory nodes are. While in the ISTO cases, they have included the interpectoral group. That is the SCF node were reduced to the upper edge of the subclavian. And the mainly it is in the ISTO guideline, they have 5 mm around the vessels. Then next, the RADCOM guideline, they have similar, something is different, but mainly majorly there is a posterior neck proposed, posterior neck in RADCOM, where in the highly node positive cases. So which to be used and in which condition?
So then there is a personalization. Elistro is mostly conservative, a small value that easily can be practiced in the T1, T2 cases, no negative cases, as the validation study has shown about 30% failure if Elistro guideline is used in LAB. To treat specific regional nodes in the areas with the breast cancer like internal memory, everyone knows it is the medial and central, more than 4 node positivity, or 1 to 3 node positive with other high risk factor like AMH, LLVI, T3. When to omit? When the lateral tumor 0 to 3 node, no high risk factor. Supraclavicular, more than 4 node positive, 1 to 3 node positive with adverse factor. And it can be omitted easily in node negative cases. The supraclavicular node is mostly treated with the level 3 node and same indication. Posterior radially, as we already discussed, in heavy node positivity. Level 1 to usually explode, surgically explode, but in the cases in India it is less practiced, where it practiced is sentinel node positive, sentinel node lymph node biopsy was done, and no axillary dissection done in second phase. Then this situation arises. But mostly in India, in practice, if sentinel positive, they complete with the axillary dissection. So this indication hardly we see. How to control lumpectomy? Previously it was very easy. Seroma with 1 centimeter margin, crop 5 mm from the skin and chest wall. The specimen, you see the specimen and tumor symmetry. It is always asymmetric and eccentrically placed. There is few margin are close, few margin is very large. So what the pattern of area study shows is the margin which is closed mostly see the recurrences around that. And the margin which is distant, they have hardly can see any recurrences. So if we practice any guideline, if we take tumor with 2 centimeter, then just 1. So it is we have to take surgical margin plus pathological surgical margin plus recommended radiation margin equal to total 2 centimeter margin for CTV delineation. So it will come like that, the proposed lumpectomy cavity. Angioplasty make it more difficult. We have to place the clips and see the operative nodes. It is the implant cases. RTOG में implant target है और stroke में it is the OAR. The conclusion, procedure in the breast radiation therapy is not mainly about having advanced machine or following controlling guidelines. True precision lies in the critical application of evidence, clinical judgment and personalization, tailoring the target technique and technology to each patient's unique anatomy, biology and risk profile. Thank you.
Present here. First of all, I would like to thank Dr. Chaturvedi sir for giving me this opportunity. So my topic is personalized radiation therapy in the carcinoma breast, and this is as complex as the breast cancer itself. So during the last 50 years, we have seen many advances in technology and the tumor biology. We have the better knowledge regarding the tumor biology. So this has made enabled the radiation oncologists to personalize the radiotherapy of the patient with breast cancer. Traditionally, one-size-fits-all radiation therapy may not be the most effective and least toxicity approach for the every patient, so we need to personalize. Why we need to personalize? Because each patient is unique in body size, breast shape, cardiopulmonary functions. Tumor factors may be variable in different patients, like the location of the tumor, molecular subtypes, and cancer proximity to the critical organ. There may be the anatomical changes as the tumor bed position can be changed, seroma cavity may be changed, so we change the anatomy of the tumor itself. So the personalized therapy account for these dynamic shifts. Personal radiotherapy involves tailoring the treatment for each patient's specific anatomy and the tumor biology. It involves the clinical factors to optimize outcomes, simultaneously minimizing the side effects. How to do the personal radiotherapy? There are the various methods. First of all, we have to choose patients to whom we can de-escalate the treatment or escalate the treatment, or in which patient group we can omit the radiation. Advanced treatment techniques, we can give the more precise radiotherapy. We can adjust the dose and transmission schedule as the patient's molecular biology. Adaptive radiotherapy has a basic major role in the case of the personal radiotherapy. And the lastly, the genomic and the molecular profile, which can guide us to define the personal radiotherapy. So what is the benefit of the personal radiotherapy? Here you can see that when we give the conventional radiotherapy, we only take account the standard protocol and the tumor conformation. While doing the personal radiotherapy, we basically take the account of the tumor conformation, tumor clinical molecular heterogeneity, and damage of the normal tissue. So we can give a holistic treatment to these patients. I will cover one by one. Optimal patient selection. This is very, we should basically, should be very judiciously to select the patient to whom we should omit the radiation therapy. There are various trials. I will cover only the landmark trials like NSA-TV21, which has showed that RT could not be omitted in women with a small, even small, less than 1 centimeter breast cancer. But it was the GB study trials which has concluded that the women of 70 or the more than 70 years of age with ER positive disease, with T1 and 0 disease, we can omit the radiation of the BCS. Lumina trial was the first trial which included the tumor subtypes, that is the luminous status, and it has concluded that ER positive patient can be omitted with T1 and T2 and 0 disease for the radiation. So lastly, after all these trials, we concluded that NCCN guidelines, according to NCCN guidelines, patient is more than 70 years with ER positive disease, with T1 and 0 disease, can be omitted from the radiation after the BCS. But there are some loopholes with these trials, because these trials has not commented on the compliance of the endocrine therapy. Only 40% of patients receive the proper endocrine therapy. So we cannot conclude only the ground of trials that this patient should be omitted. But as we follow the NCCN, only the ER positive patient with early breast cancer can be omitted. The second, the radiation therapy techniques. We know that most of the recurrence occur in the tumor beds. So the concept of the partial breast radiation came into the view. I am not getting detail because technical part will be covered by the second speaker. But the major point is this was the NSA-BP trial. We showed that if we treat the early breast cancer, it has been seen after the 10.2 years follow-up that incidence of the local recurrence was approximately equal between the APBI and the whole breast radiation. These are the various indications for the APBI, like for invasive, this is the grade 1 and 2 ER positive is equal or more than 40 years with T1 and 0. For DCIS, it may be the
JPG उठा रहा है
indication, but some indication are also there. Another technique for the less breast radiation is the deep inspiration breath hold, that is DIPS technique, which increases the distance between the heart and the basically chest wall, so that we can reduce the heart dose. For DIPS, there are different techniques to more precise the dose. DIPH, technetium IMRT, DIPH, technetium VMAT. It has been seen that DIPH, technetium IMRT has the more precise dose to the tumor by simultaneously sparing the heart. Another technique is to treat patient in the prone position. It also basically reduces the dose to the heart. There was the dosimetry and the radiobiological comparison when treating the right breast tumors using the SIP technique, and it has been seen that if you use the hybrid IMRT techniques, then it is more precise for these type of the patient subject. Proton-based radiotherapy is another technique, but there is no head-to-head trial comparing the proton beam therapy with the photon beam therapy in case of the breast cancer. So we cannot comment that the proton beam therapy is more safer than the photon. Third method is the fractionation schedule. Fractionation, we know that now we have come from the convention to the hyperfractionation, as we know that breast is having the low alpha-beta ratio of 4. There are various trials of the dose scheduling from 15 to now we are moving to the 5 fraction. But current NCCN guidelines recommend that hyperfractionation, that is defined as 40 to 42.6 into 15 to 60 fraction, should be used only for the whole breast radiation. Alpha hyperfractionation, we define it as 28.5 gray in 5 fraction, 1 fraction per week. It is reserved for the patient of age 50 or more than 50 with early stage non-negative disease. While this fast forward trial, that is the completing this dose in the 1 week, the 5 fraction is still not in basically not recommended. It is expected that after the completion of tender follow-up, it may be recommended. Conventional fraction radiation therapy usually reserved for the nodal radiation or the post-mastectomy patients. But few patients of the post-mastectomy can get the hyperfractionation of 15 to 16 fraction if these are not considered for the reconstruction. Fourth technique is adaptive radiotherapy. Adaptive radiotherapy, we know these are the use in this patient where the seroma cavity is there. We think that during the radiation seroma can be shielded so the anatomy of the tumor can be changed. So adaptive radiotherapy is basically used in this type of the patients. This was the one trial which has shown that high-dose adaptive radiotherapy was used very efficiently in operating breast cancer patient with skin invasion after failure of the chemotherapy. Now coming to the last method, that is genomic profiling of the breast patient. Basically, when we talk about the genomic profile, we divide into two. One is the pathobiological driven, that is the luminal type, and the second is genomic driven, personalized. So when we talk the molecular type, we know that the luminal A, B, and HRU2 and basal-like molecular subtypes having the different disease outcomes and the treatment response. Various studies have been shown that if we combine these luminal types with the other molecular factors like HIF, CAS, blue, so it has been seen that after 10 years, local recurrence was minimal in case of the luminal A and basal-like, while for the luminal B it was 79%, it was highest in case of the HRU tumors. So we can say that commercial level genomic assays have now been developed and are commonly implemented clinically as prognostic and predictive tools for the adjuvant systemic therapy, but to come in for the adjuvant radiotherapy is still under the investigational. Now, various trials have been done to assess that this type of surgery is correlated with the tumor molecular subtypes and the post-operative radiotherapy and what are the outcomes. There are some common, there are some landmark trials. One is the Danish breast, which has shown that post-operative RT significantly reduced the probability of local lesion relapse in the receptor-positive HER2 negative tumors, receptor-negative and HER2 positive tumors, and triple-negative tumors. But it has been seen that it is associated with the significant better overall survival when tumors were hormonal positive. So overall survival is basically better in case of the HER positive and the HER2 negative tumors. Toronto trials, Swedish trials have been done, and overall radiotherapy significantly reduced the risk of local regional recurrence in mastectomized luminal A type, but its impact was not clearly seen in case of the BCS. This was a very good study which showed that whether this fascination is basically vary upon the luminal type, and this concluded that hyperfascination can be safely and effectively be tried in all type of the luminal type of the cancers. So why genomic analysis? Because it is a potentially powerful tool to improve the risk stratification and personalized approach to radiotherapy. As individual gene profile, we overcome the limitations of the biopathological markers like subtypes. There are some predictive index. Multiple variant analysis has revealed that besides the stated genomic predictive index is the only independent prognostic factor for the local lesion relapse after post-mastectomy radiotherapy. Gene expression analysis identifies 7 genes and a gene expression index was derived, that is DPCG, which was basically used for the stratification of the patient and which subgroup of the patient should receive the post-op radiotherapy or not. Apart from this, gene expression profile has the good response signature 70 gene, prognostic profile and the hypoxia profile. Now coming to the radiosensitivity index, this has been clinically validated in 3 independent databases of different tumors, and it has been found that if we combine this RS LRR. So validation in the prospective randomized trial is however needed before the radiosensitivity or the anti-tumor immunity signature might eventually be adopted in the clinical practice. GRD is a genome-adjusted radiation dose is a new concept, and it is derived from the combining the gene expression-based radiosensitivity index with the LQ model. And it has been emerged as the only independent predictor of DMT survival. If we have hypothesized that GRD could predict the local relapse, it has been tested into independent database of tumor triple negative patient, and it has been found that triple negative tumors is described as the two subgroups. One behave like the radio-resistant tumor, and the other type of this variant act as the numeral types. So this can give an insight that we can enhance the radio-resistant tumor or the tumor negative, and we can go up to the 70 grade in spite of the increased risk of toxicity. This article is the basically trial is was to tailor the response of radiotherapy, and article is a highly prognostic tool in the patient treated with radiotherapy. When there is a low article score, then 10-year cumulative incidence of LRR is significantly reduced. But in case of high article score, the radiotherapy has been less benefited. There are various trials showing the gene expression in its outcome. So I will not go through this because of the paucity of the time. There are the various prognostic genomic assay in breast cancer, OncoDS, which has been the 21 gene panel, MammaPrint having the 70 gene panel, and PalmFit is having the 50 gene test. All this basically interpreted in terms of the recurrence score. For oncotype, this is from 0 to 100, and for MammaPrint, it classifies the prognostic band, which is also having the risk of the recurrence score from 0 to 100. Unfortunately, all these assays had basically given the guidance regarding the low risk or the high risk, but for intermediate risk, these are not basically used. So for intermediate recurrence score is the Devansh trial, which has shown that for intermediate risk score patients, you either give the endocrine therapy or the chemotherapy, response will be the equivocal. Node positive patients, for node positive, another trial is going on by SWOT. So now coming to my question, now the OncoDS assay and the radiotherapy impact upon the overall survival. Yes, it has been seen that post-treatment RT was associated with longer overall survival only when relapse score, the recurrence score was low. But caution should be exercised when omitting the post-mastectomy radiotherapy in women with the low relapse score. Whereas is, I am not going through it, TIL. We know that high TIL is associated with a good response with immunotherapy, but for radiotherapy, some trials are going on, and we hope in future we will also get a guidance regarding the TIL status. This is a very good article of the genomic guided breast radiation therapy for the PG. I would like that they should read this topic. So, nurse, and what is the future of personal radiotherapy? Artificial intelligence will likely automate the treatment planning, making adoptive radiotherapy more efficient. Integration of MRI screening in the MRI scanner with the linear oscillator will enable real-time tracking of the tumors, so we can more precisely do the radiation delivery. Integration with the systemic therapy will basically help in more holistic and the patient-specific treatment plans. So to conclude my presentation, personal radiation therapy has moved beyond a one-size-fits-all approach to a highly tailored treatment that considers the patient-specific biology and